Hello, I'm Dr. Amar Chauhan from VERVE Medicine Hub, and today I'm going to talk about very important topic, and that is how to develop an emergency mindset in India. And I would highly recommend that you read the Niti Aayog report, which is titled Status of Emergency and Injury Care at District Level Hospital in India. This report is available on internet, and the study was done by AIMS. So I'll just enumerate the important finding of this report. The number one is that there is no pre-hospital care in India. It is almost non-existent. Secondly, the sickest of the patient are seen by the most junior doctor. Usually, the senior faculty is not around to help them. Then the investigation, diagnostic tool like ultrasound or CT scan, they are not available most of the time, and they are almost non-existent in the night. And then all those who are working there are not trained in emergency medicine. And then our health worker, our healthcare provider like emergency medical technicians or nurses, they are not trained. Like only I think it's up to 4% they are trained, and they too are not certified by various courses like ACLS, BLS, or ACTM or PALS. Okay, so these are the salient findings by the Niti Aayog themselves. Now, when you read this report, you feel very uncomfortable. It gives you a lot of distress. You feel butterfly in your stomach. But we need to care our patients with whatever we have. So, like in India, if you are working in emergency department, you need to have some attributes, some concepts or some features by which you can work efficiently. Because we know that we are not working in state-of-art department, and our infrastructure is also, not adequate and proper. So, why it is necessary to develop that emergency mindset? I'll just illustrate with an example. Like if a person is selected in an army and he is given a gun, so doesn't mean that he will become a soldier. No, he will have to kill, or he can get killed for the country. So that mindset we need to develop in him, or he need to develop that mindset. So because in emergency there is a rapid decision making. It's a challenging environment. It's a dynamic environment. It's changing all the time. So like we cannot have a particular type of a mental makeup so that we will be treating all the patient. And the patient presenting there, like the dictum in emergency department is sorry, anything, anytime, anyone. So we need to train ourselves in multidisciplinary terrain, and because it's a challenging environment, and we need to sometimes make a decision by pattern recognition, because when the life is on line, when there's a life threat, we cannot be doing maths, we cannot be calculating. So we need to train our system 1 and system 2, and definitely this is a very rewarding field when you temporize the situation, or you control the condition of the patient. Then definitely this is very rewarding and fruitful. So I would say, because we have resource limitations, and if we work with that mindset, then definitely we can use our resources judiciously also, because then something like emergency action drill, somebody comes with this kind of pattern, then we will be doing this only. We will not be wasting our time and resources in thinking other stuff. So, and then we have to have collaboration, we have to have communication, team dynamics. So all those things we need to have before we hit the emergency department. Now, if I talk about these factors or these attributes, the first and foremost is the solid training base. As alluded earlier, like as reported in Niti Aayog report, that most of our healthcare providers, they are not trained. So we should be trained in life support courses like BLS, ACLS, or ATCL or LEPAS, so that whenever patient comes, we are on the same page. I'm not talking about the doctors only, but healthcare providers, our nurses, our EMT, so that we can be on the same page, and we can understand, we can speak a common language, and we can treat the patient in a very effective and swift manner. So, but that is missing from Indian scenario. So, if we are not able to afford our, the imported courses, then we must, like those who are in this leadership role, they should utilize these courses, and then our all healthcare providers, doctors, nurses, EMT, or paramedics, whoso they are working anywhere, they should be trained at least in these life support courses. Okay. The second is the situational awareness, because as I referred earlier, the emergency department is not static; it's dynamic. It's changing all the time. So sometimes we get patients which, at the time of presentation, they are quite, they look normal. Like if I illustrate, like a patient of chest pain comes, you run an ECG and there's ST elevation. Okay, you organize his cath, but suddenly he became unresponsive. And then you are doing his CPR instead of like the patient going to cath lab. So we should be aware of that, because anytime we cannot just say, we cannot blame patient that he came and arrested and we could not find defibrillator. No, we need to be situationally aware that such patient, MI, can arrest any time, right? So we need to have the situational awareness is very important factor when we are working in emergency department. And like second example I'll quote is like a patient of traumatic bleed. He comes in and he's diaphoretic, he's sweating, his pulse is 140 per minute, his blood pressure is 110/70, and you start resuscitation and suddenly he crashes. Because he will crash. We should be knowing that. Why he crashed? Why does such patient crash? Because when patient comes, they are in sympathetic overdrive. They are using their different compensatory mechanism. So that's why they are maintaining their blood pressure. So the moment you start resuscitation, they can crash. So situational awareness is one attribute we must be very well aware. Okay. Now, the next is your plan B. So, like as I said earlier, anything, anytime, anyone can come, and they are very presentation, myriad presentation, different presentation. So sometimes your plan A doesn't fit in particular situation or scenario, in patient scenario. Then rapidly move from plan A to plan B. Moving from plan A to plan B is not a failure. It's a strategic completion of the procedure, especially when you are doing procedure. And sometimes, as I told earlier, like you are engrossed too much in emergency, like you lose sense of time. So sometimes it is not only you, your team member can alert you. Like I'll just give an example. When you don't have a plan B, your patient can suffer. Like I'll quote the example of Miss Ellen Bromley in United Kingdom. She went for a simple nasal surgery, and after paralyzing the patient, the doctor was not able to tube her, and then one after the other doctors tried. They kept on trying. They somehow, sort of got fixated at intubation only. Nobody prompted them to, or they thought themselves that they need to do a rescue surgical airway or a emergency tracheostomy. Now, here, like that time, there was some problem, like there is no just culture, there is a authority gradient, so junior doctor cannot speak. So sometimes not having a plan B can result in patient death. So like when we are doing any procedure, we should have a backup plan B. Now the next is the cognitive aid. Now it is not important, or maybe it's not possible all of us to remember all algorithm, SOPs or guidelines or information. So when the information is readily available on the net, then we can use that information or that knowledge or those resources to make any high-stake decision. So one of the team member or the recorder can be on the net, and they can tell us about the various things which are likely to be missed. Like if we are doing a cardiac resuscitation and somebody has forgotten, and it is likely like 5H or 5T of cardiac arrest, then one can always go and check on the line, so that at least we will cover all those aspects. The next is the cognitive biases. Now this is a very important factor, and it is not possible to rule out all cognitive biases, and I have read that more than 60 biases are there when we are working in medical field. So how to avoid that? Like just to go, let me tell you, we were having discussion in group, and there was a traumatic evisceration, and surgeon did a wonderful job. And then He told me that there are many problems with this patient. There are high chances of sepsis, but he told me that he will survive. He will make it. I think so. So this assumption is cognitive bias. So the cognitive bias is making assumption about complex things, making them simpler, although they may not be logical. Okay, they may not be objective. They may not be fact-based. So as far as possible, we should avoid cognitive bias. Now, cognitive weight, like I'm reading, it's not that I remember everything. So this is cognitive weight. I can look, this is not crime. Okay. So the next is the flexible or the intuitive or the adaptable. Flexible thinking. You cannot be dogmatic, rigid all the time. Okay. Your thinking needs to be flexible. Like I will illustrate with example. The patient agitated, alcoholic, he has come full stomach, he's vomiting. Okay, of course, you need to decompress the abdomen, but if it's too agitated, then we can wait some time. And because I have seen when such agitated patient come and we try to decompress by putting Ryan's tube, then there can be nasal bleed. Similarly, when we are resuscitating cardiac arrest and we are doing BVM, the return ETUs are good in number, then there's no need to rush for intubation. So this is like flexible thinking and or the intuitive thinking. So here I would like to mention Captain Sully Sullenberg, who flew Airbus from New York, and just 3 minutes in the flight, his plane was hit by Canadian geese, and both of his turbine engines they choked. And what to do? 3 minutes in the flight, and both engines failed. He could not go backward. He could not go forward. There is nothing. Like according to him that time he could think of any salvageability. But you know what he did? You know when like you can put the failed algorithm in the same category. When the algorithm failed, so there is no algorithm what he did. So he did like he landed the plane on the water of Hudson River in New York, and all the passengers, like all 154 were safe. So we need to be flexible when algorithm doesn't fit in a particular patient's condition. And we know in India, algorithm fail quite often because our working culture, our injury pattern are different what are described in books. Okay. Now, next is don't give opportunity for unnecessary failure. I mean like when we are intubating, like we should be ready and optimally prepared when we are doing some procedure or some skill. Like if you are intubating, then make sure that the proper positioning of the patient, like the external auditory canal in plane with the sternal notch. Okay, we are having adequate support. Then only we should proceed. Or when we are intubating, we should proceed with a suction device, because when you after paralyzing, when you open the mouth, then what you find is secretions inside. Then you run for suction. So it is better to have suction along with the laryngoscope. That's like not giving opportunity for unnecessary failure. Like for medicine side, if there's a patient in critical care unit and his legs are swollen, please go and find out if there's a DVT or not. Let's not leave it like that, because we don't want next day patient going into respiratory failure because of the pulmonary embolism. So that's one concept, that we should not give opportunity for unnecessary failure. Now, next is the pre-mortem or the mental visualization. So this is a skill I think by Gary Klein. He's a behavior psychologist, and there he described that you conceive a project, and then you suppose that this project has failed, and then you discuss various causes of that project failure. So similarly, I would say like a patient of chest trauma comes. Okay, now we assume that the patient has died. Now, what are the various reasons the patient could have died of? This could be like massive hemothorax, tension pneumothorax, or multiple rib fracture, maybe flail chest, or maybe aortic injury, esophageal injuries, and maybe tamponade. So when we imagine all these injuries, then when the real patient comes, because we are mentally visualizing all the time this complex scenario, pre-mortem is very important when you are dealing complicated cases with bad outcomes. So everything, like you are running those scenarios multiple times in your brain, and when real patient come, then it's very easy. Like, it's not very easy, but it's comfortable. Like, you will be attending, you will be thinking of all injuries, because everything is in your head and you need to put that into action. So pre-mortem is a very, very important skill when you are working in emergency department. Okay. Now next is the dealing with uncertainty. So when we are working in emergency department, we sometimes get patients who are very sick, who are like fatally injured, like unsurvivable injury. No matter what we do, patient doesn't make it. So how to deal with that? So we must not suffer from imposter syndrome. We must not doubt our capabilities, our caring attitude, because we have been doing these things for many years. And sometimes, yes, there will be, unpredictable outcome. So that should not dishearten you, but your intentions should be honest, and that's one thing we must keep in mind all the time. And the last is never waste suffering of your patients. Means there's a patient of traumatic cardiac arrest. He comes to you, you do resuscitomy, you perform other things optimally, but patient cannot make it. So you can learn from your mistakes. You can learn what are your blind spots. It's not easy to see one's blind spot. They are not visible to us. They are visible to others. So you can talk to your fellow member. You can talk to your team member, like about the blind spots. So then only you can learn from the suffering of your patients. And these are the, I think, now how can we correlate, or how can we contemplate or transfer these attributes in emergency setting in India? Because our department, not the state of our department we are working, there are so many problems, so many challenges. Like it's very frustrating, to be realistic. But whatever is there, we have to work with that. We have to care for our patients, because a doctor can cure sometime, treat often, but can comfort always. We must comfort, we must give whatever relief we can with our best effort, with all preparation. So whenever you work, you develop compassion, your sympathy or empathy. I know these things are easier said than done, but I think nothing is unsurmountable, nothing is impossible. We need to have good intention, honest intentions, and then we, with 0-point survey, we need to do 0-point survey with whatever facilities or equipment we have, and we can use the acronym STEP UP. I think we need to start a culture of research readiness with whatever we have. So once we start that, and I would urge our leaders to have all these courses mandatory for our healthcare providers, so that the culture of research readiness is established, it is maintained. And with that, thank you very much for your time.